What I tell you, folks? Didn't I tell you? Good morning. We're at Circuit World in Blue Ridge, Georgia. This is Ask the Doc with Dr. William Whaley and Raymond Tidman. What I tell you before we started, that is the nicest. I go to so many meetings where people wear patriotic ties and shirts and stuff, and it's great. That's the nicest flag tie I think I love that tie.
Why am I wearing it?
You will let me have that one day? Go ahead.
Why am I wearing it?
You answer that.
I'm going to tell you why I'm wearing it. Okay. Between the end of the Korean War and the start of the Vietnam War, if you went in the reserves of the National Guard, you were there as a safety valve. You didn't really do much. You drilled and you got out 6 years later. And after Vietnam, before we had Desert Storm, that was the same thing. But from Desert Storm until we got out of Afghanistan, which is 21 years or something, the reservists and the National Guard were just like everybody else, and they were activating them and sending them. And so last January, when we made this ignominious withdrawal from Afghanistan, those guys went home and, they thought they could go back to their lives teaching school and stuff. And now there are about 101,000 troops in Eastern Europe. About 12 or 14,000 have been sit there in the last 4 weeks. And they've come back out of their schools and everywhere else and got out of their jobs, and they've gone over there. I don't have the foggiest belief that they're going to have a war with Russia, okay? But it's disrupted their families and the jobs that they have and have done. And I think people...
For a political show.
Well, I'm not getting into that, but my point is that I don't think people out there appreciate the fact that that our military represents about 1/2 of our population, and the reserves about 1/10 of 1%. But they're constantly called on to go out there and stand between Godzilla and us, and everywhere in the world. And I just saw that family, the couple of families down there at Fort Stewart loading up on you saw that. What was it, 3,000 of them down there in the middle of the week last week, getting on those big old airplanes, those little kids standing around there pulling on their daddy's legs, and thinking, thank you, guys. And so being a Vietnam veteran, I said, I don't know. I was going to wear my shirt today.
And I'm glad you said that, because the news will say we're sending, the news will say today the president made a decision, they're sending 3,000 more troops to Poland, or 3,000 here. That's a number. But what people don't, and I'm not saying they do it intentionally, but what people don't think about is those 3,000 are people that get called up,
right?
People that have families, they get activated, there's a goodbye.
Yeah, and then you don't know how long they're going to be there.
Right, and so I appreciate what you said, because we are calling up enormous amounts, numbers.
Well, and the other thing they're doing that's sneaky, they haven't told you about it. Like at one time, I saw one thing where they moved 2,000 Stryker troops out of Germany,
right,
over to Latvia or Poland or somewhere. Now that's people that don't travel don't know much. That doesn't sound like much, except that Germany doesn't border Russia, and so they took these people that are really pointed the spear and moved them right to the border of Russia. That's
provocative.
It is, and they didn't have to bring them from here. They're there. They've been there, and they're very important there. And the 101st Airborne, they've got a place in Vicenza, Italy. That doesn't border Russia either. They've gone up into Romania or somewhere.
What?
So you moved a bunch of troops who were already over there. There were 91,000 troops over there all the time. Well, they moved about 6,000 or 8,000 of the toughest of those up there that you don't see. So I don't know.
The other thing that's coming out of this, Bill, is that even for our own culture and our own knowledge of our own people and what's going on with them, we're pretty uninformed. And you're informing people. My older brother was stationed as a missionary for the Salvation Army in Russia for a number of years. And I was talking to him about that culture and what's going on there and how much Putin's liked or not liked, and that's a whole different story. But he said, Ray, all of the people, all the men except for the officer corps are conscripted in Russia.
Yeah, oh yeah.
Says you can
No
have a son-
volunteerism.
No volunteers there. You can have a son who's 20 years old that you sent to the grocery store who doesn't come home for 2 years because he didn't have the right papers on him, and they said you're coming with me, and he's put in the army and he serves 2 years and then he comes back. So I mean there's no freedom about it, and there's probably not a whole lot of loyalty, but it is getting people killed.
Well, anyway, so when they activate those guys, they have to activate doctors and dentists and nurses and stuff
Support
too.
people.
All right, let's go to work.
Well,
We
I
got
want
work
to say this and go to work. Thank you for bringing that up, because we're disrupting people's lives all around the world and families, and they're making major changes in their life, and we need to acknowledge that's happening.
That's right.
And show our support.
That's
Thank
right.
you.
And when they talk about stuff on the news, they never mention it.
By the way, I like that topic.
Okay, we've got some really great questions today that revolve around a lot of primary care issues. And interestingly, of all the things we've been talking about for such a long period
Well, I
of time.
know a guy. If
You
we
do.
talk primary
That's why
care.
he's here.
All right.
So this first question is going to bring in some things that we've touched on in the last, say, 6 months, but it's going to highlight them really well about how the science of diagnosis and the science of evaluation of malignancies gets you to a point where modern technology and advancements can show you the great progress that has been made. This is an interesting, listen to this one. My father is 73 years old, and in 2010, he had an early stage lung cancer removed by surgery. He continued to smoke until 10 months ago. On his annual smokers monitoring chest CT, remember now, primary care docs, if they got somebody that's smoked over 30-pack years, can get them a CT scan every year as a early screening thing, like a mammogram or a PSA. So he has been being followed by somebody greater than 10 years out, still getting those CTs. In February, there was a 1 centimeter nodule in his left lower lung, and the cancer had been in the left upper lung. So, the oncologist expected this to be a recurrence of lung cancer. Now, previously I've said, you know you're cured of cancer when you die of something else. And so 10 or 11 years later, you would not ordinarily expect that tumor to recur, but it could be a new lung cancer because of the smoking history, which is why they have them do the CTs. All right, but the biopsy revealed a poorly differentiated cancer. So this is what's called cancer of unknown primary. You don't know exactly what it is. And then they went through a procedure called immunochemical stains that looked like melanoma. We then learned that 5 years ago, a dermatologist did Mohs surgery for a superficial melanoma. So you wouldn't expect a superficial melanoma to recur, which means probably the pathology on that wasn't good, or he's had another melanoma somewhere that has just regressed, because melanoma doesn't start in the lung. His lungs are so bad that he cannot stand the surgery required to remove the nodule.
You need to emphasize that.
Yeah, so you want to emphasize the fact that if, under normal circumstances, with a spot on the lung, nothing anywhere else, you'd remove it. Okay, now, he then had gene testing. Now, we've been talking about gene testing and so forth, and he had a BRAF gene. Well, it doesn't make a difference what that is, but what that's going to tell us, I'm going to show you in a minute, is, so you go from a patient that you think's got lung cancer, where you generally would end up with chemotherapy and surgery, and then through a variety of special tests, you discover that he has a genetic marker called the BRAF gene that's going to make his treatment really easy. And it used to be we had nothing for melanoma, and you had melanoma, you were going to die, period, if it was recurrent. All right. So
Where did they get the material for that gene test?
Huh?
Where did they get the material?
Biopsy. From the biopsy.
It wasn't a blood test. It's not a urine test.
No,
They
no,
had
it's
to go get tissue.
From the biopsy, yeah. Now, we can get into somewhere else, but there are liquid biopsies where you can take blood with many cancers, ovarian, lung, and lots of others. It'll have enough cells in it circulating that you can get the test done on that. But to do this, you need tissue. Okay, show that first one. This is cancer of unknown primary means that somebody pops up with a malignancy that you can't tell where it came from. And this picture here just shows that somewhere down in the body, there's a cancer that shows up, and this one showed up in the lung, or it could show up in the brain, or show up somewhere else. And it gets there by traveling through the bloodstream or the lymphatics from an unknown site. So pull that one down. So what we tell you, what they say that they did when they had this unknown, poorly differentiated tumor, they finally decided it was a melanoma. Well, what's this here?
An algorithm.
All right. Well, you're not going to have to look at this, because this algorithm is about 50 different what are called immunostains, where you can pull that down. I don't want to confuse people, but these are different immunologic staining they do on this. Cancer, where they put a stain on it. If it picks it up, let's say they had a stain that goes against prostate specific antigen. Well, if that popped in there from a lung cancer, you could say that thing probably came from the prostate, or there can be some from the breast, or some from the lung. So you have different markers. Well, when they applied all these markers to this guy, what popped up was a melanoma marker, which they certainly didn't expect. Now go to the next one there. So this is the algorithm that's another algorithm I got you for you here.
Yes.
Cup algorithm. So what you generally used to do with this was, the old way was that if it was above the diaphragm and it was a squamous cell, then it must have come from the lung or the head and neck. If it was adeno, then it probably came from the breast or the GI tract, and if it was below the diaphragm, you had a similar algorithm. But if you go whipping through this thing right here, where you do all of these different tests, way down here at the bottom, you got a place where you can send this tumor off for other immunostains. You can pull that down now. That's called a specific tissue of origin test, that if it's negative, then then that's when you go to the gene testing. So we went to the gene testing. Go put up the next one. Oh, the next one just shows that you have to, before you get to treating the guy, you've got to do a bunch of scans, right? You got to show that you don't have something in the kidney or somewhere else. So this is just the long list of places that you go. But female patients with a carcinoma that's an adeno anywhere in the body, you got to go do a mammogram, for example. And people who have males with adenocarcinoma, you got to go do a GI workup. So pull that down. But that tells you why you have to do a bunch of other tests. So now we're going to talk about melanoma for just a minute. Melanoma rose dramatically in incidence in the last 20 years, up 108% in that 20-year period, 40-year period. 108%, that's a big number, isn't it? That's 2 or 3% a year. The mortality went up during the period up until 2013, and then fell almost 20% starting in 2013. See that? Can they see that pretty good? Pull that down. So how in the world did it start killing more and more people, and boom, something happened in 2013?
I'd like to know really quick, what is this here? What is this 108% increase from?
In incidence. That means that you diagnosed more melanomas by, that's double. That's
100% increase. If you had 100 cases per 100,000 people, the next time you looked at it, you had 200 per 100,000.
Yeah, but it's a lot more. It's a lot more than that. And the reason for that is several. One, we live in longer, and two, people got a lot more recreational sun back in the day. All right, so now basically here's what happened in 2013. They came up with the first of these immunotherapies. Remember the drug we keep talking about, the Jimmy Carter drug, Keytruda, those were the first ones. And there's a bunch of other things on there. So pull that thing down. We're going to talk about this guy's specific BRAF mutation, all right? This is a pie chart of melanomas in general, and BRAF is about a third of those melanomas. Now that's a pretty good number. And then there's you don't care, but all these others are other genes. But in that 1/3 of people that have the BRAF gene, pull that one down, the treatment is easy. It's Jimmy Carter type drugs. Now remember, we talked about immunotherapy before. What does immunotherapy do? Do you remember? Ray remembers though. Okay, here's the story. A cancer turns off the T cell lymphocyte, which is the killer cell that goes around and kills cancer and kills bacteria and kills other things. And the checkpoint inhibitor blocks the ability of that cancer to stop that T cell from working so it can come around and kill the cell. And melanoma is what Jimmy Carter had. And he had a BRAF gene mutation. And so what that guy is going to do is get the Jimmy Carter drug after. You still have to do something about the spot, don't you? You haven't thought about that. Remember now, breast cancer, you got adjuvant chemotherapy, colon cancer, you got adjuvant chemotherapy. So what you're going to do about the spot, can't operate on it, can you? Now, do you remember what we do for cancers that you can't operate on because the patient can't stand it? Now, sometimes you got cancer that spreads, so you can't operate on it. But if you were going to operate on him, then that means that under ideal circumstances, if the patient were you, Ray, or me, we'd operate on it, and that'd be the end of the local control. So what do we have? Gamma knife, remember?
Yeah,
the X-ray knife. Come on now, you're not.
Yeah, but I mean,
you're not a doctor,
it's
but
early.
you play one on TV.
Yeah, gamma knife. How could I forget
the gamma knife up, Bart? That's the one. All right. So remember what this gamma knife is. See this little cancer over here in the lung? This beautiful picture of all the colors over there. They will be able to put high-dose radiation therapy right on this. Just a centimeter. It's 2.5 centimeters is an inch. So this is less than half an inch big. So they're not going to destroy much lung by really burning that thing with a bunch of radiation. You can pull that down. So after that's been done, then he'll get the Jimmy Carter drug to prevent it from recurring. And all of that's going to probably save his life and allow him to go on and die of chronic lung disease or something else is stuff that has happened in the last, 2013. So it's happened in the last 5 to 7 years. And it's not surgery. It's not radiation. It's genetics. There.
So I have a patient who was diagnosed with a melanoma, had the wide resection, big scars on her leg. You watch those people carefully. 5 years out, she's melanoma free, and things had changed in her life, and she'd gotten into a really happy relationship and kind of neglected her screening test, and then turned up with another spot that was metastatic into her brain.
So she didn't go back every 3 to 6 months for skin inspections and get treated?
For 5 years she did, and then she
quit. That's what I mean. Quit,
right.
Yeah.
So anyway, and that was right about the time Jimmy Carter was diagnosed and getting his treatment, because he was in the brain. And that drug was just really being made available in special cases or was being rolled out there. So it's a tragic thing that she didn't survive, and she didn't survive because she didn't keep up her surveillance, because she thought she was through all of her surveillance. Well, you don't quit looking for melanoma. I mean, you back off a little bit. What do you say about that, Bill?
Well, I'd say that you're cured of cancer when you die of something else. So you basically, let's take breast cancer, and you're actively treating it. You actively treat that for about 2 years. Then you follow them every 3 months up to 5 years, and every 6 months up to 10 years. But you have an annual big-time exam you do every year for a cancer patient survivor.
And the other aspect of this is that the patient had no reserves left in their lungs. So we're born with over 10 times the amount of lungs we need. So what do I mean by that? You need enough lung capacity that you can sit up, move around, carry on day to day, and ventilate yourself enough to get oxygen into your system. So that's one. If you had a level of 1, you can do all those things. Probably couldn't get out and run. You certainly couldn't go run a marathon. Being born with 10 or more, I mean way more than 10, you've got lots of capacity. So you could lose half of your capacity and still function just fine.
Yeah, we were going to be talking about that in the next question.
Yeah, well, I'm kind of leading you up to that next question. 'Cause
Okay.
I read your emails. So the important thing about this fella is he's now down to the point where that they can't even go in and take a little wedge of lung out because they would take out too much lung for him to even be above water. I think of the horrible thing about dying of lung disease, end-stage lung disease, COPD, chronic obstructive lung disease, is that you're drowning. And you've got a little straw, and it's the last little thing that's getting up to get you air. And it's a terrible place. And so it always blows my mind when I see a respiratory therapist taking care of one of those patients dying in the ICU, and then they go out and smoke on their smoking breaks. That's how bad of a habit it is. So.
Yeah, and that's why when you have a patient with chronic lung disease on hospice, one of the drugs they use frequently is morphine because it diminishes the air hunger and the anxiety. Actually, it improves their ventilation because they're not panicked. So, anyway.
I know in the interest of time, we got to get to the next one, but I got to ask a question because you brought something up. So what you're saying is we're born with 10 times more
capacity.
Yeah.
You can get sick and still not be
function.
Dying. Yeah.
So if you say, well, I know this man or woman in their 30s and they smoke and it doesn't seem to bother them at all.
Yet.
What? Yeah. Well, you're saying yet, but say well, it doesn't seem to bother. What's happening is their capacity is diminishing, but it doesn't seem like it on the outside because they haven't got here.
You got it.
Right? Is that right?
Right. I do pulmonary function test on them, and I can show them where here is. So I can get a number, and I can say, these are your numbers. You need to know that you are on the edge here. A cold could take you out. So you've got to call me with an infection. You get a fever or you get a cough or something. You can't wait a day or two. I need to know. Some of those people, I will have a standing prescription for an antibiotic. I say, you get sick over the weekend, you fill this and call me on Monday, or because you couldn't reach me. And that's a terrible place to be in life. This is a patient who was in that place in life where they didn't have any reserve at all.
Well, I used to ask the patient, I say, look, if you were out in the middle of the Ingalls parking lot over there and somebody snatched your pocketbook, would you be able to chase them down? Or if you're out in the middle of the Ingalls parking lot and suddenly a rainstorm comes, could you run into Ingalls?
That's
and
a good
that puts it
slice
down.
Of life.
Yeah, it puts them down. It puts it down in pulmonary function testing of can you get out of the rain? All right, well, let's go to the next one because it's going to go into the comorbidities, and it's going to talk about the lung.
I thought that was that was a political question you were asking there. Can you get out of the rain?
Yeah,
I'm sorry. Go ahead.
Those two examples made me stop and I had to do a little assessment. Go ahead.
Yeah, right. You probably couldn't.
Good. Hey.
That mean not because you're lung.
Okay, go on with the next question. All right.
Well, right now I couldn't do it because of my knee.
Brian
anyway.
comes here to get abused every week.
I love it.
All right, my father is 65 years old. My father is 65 years old and has small cell lung cancer and was doing well after chemotherapy and radiation taking the Infinity drug. That's an immunotherapeutic drug they call Imfinzi. So it's just like Jimmy Carter's drug. It just happens to be a little bit different. It's used in the lung more than not melanoma. His lungs are bad from smoking for 40 years as a long-haul truck driver. So now we got a guy with bad lungs, but he's doing great from his small cell lung cancer. He fainted 10 weeks ago and had a compression fractures of his back. The hospital said he fainted due to low oxygen levels. Now, what Ray was talking about a minute ago. So he's way out. I'm going to show a thing here in just a minute. He went to rehab for 4 weeks with a back brace and has lost 20% of his body weight down to 122 pounds. Now, that's pretty thin for a guy you'd think was a truck driver. 20% of his body weight, you don't have to be a mathematician, but so 20% of 100 pounds is 20 pounds, and so if he's lost 20 pounds, he's down to 122. He's lost 25 pounds of weight in 6 or 8 weeks. That's a big weight loss. All right. For the first time since the fracture, so this has been months ago, he saw the oncologist who is to try to get him some help with nutrition. Now this comes a psychosocial sort of a primary care thing, but Dad lives alone. hundreds of miles from any family, and he will not leave to come to my house. So now we've got some family dynamics, which is always important. It's got some psychosocial things that are causing him to probably be malnourished and not getting enough food served to him, versus is it pathological weight loss? You don't know the answer to that question. The oncologist suggested that he get his back fixed by the invasive radiologist. That's where you put silly putty in there and get the pain out of there. Kyphoplasty. He can do that right above Ray's office.
Can do that upstairs.
And he arranged for him to live with a family friend who's going to feed him. So now we know that the oncologist probably has a social worker in his practice. He went to the guy, he went to his church, or he went to whatever, but somehow or other the oncologist found a family friend that's going to let him move in with him so he can be fed. He refused a feeding tube, so that tells you how bad it was. So now he's either got to eat what his family friend fixes him, because he won't let you put a feeding tube in to feed him. So that tells you this is a pretty sick guy from the eating and the strength and the weight loss. The oncologist also wants to get him back on treatment after a new PET scan. So he's been off of treatment. He was doing well on the immunotherapy. He now requires oxygen most of the time. So that tells you how bad his lungs are. Here's the question. And a lot of this question, I think, has to do with the fact that the guy lives hundreds of miles from the daughter and that she's not able to help him. Should he go back on treatment, or should we suggest hospice? So the first question here is not about the COPD or anything else, but should he be treated or be back on hospice? Or go on hospice? Well, there's only one person to answer that question, and that's the patient. And even though you might not think he's got the mental capacity to write a will or to borrow money, he certainly has the mental capacity to be able to say, I want to be treated, or I don't want to be treated. Now, this is something primary care docs go through all the time. You got somebody with a mild memory disturbance, you tell the family, say, look, don't let anybody get him to borrow money or contribute to something because he can't make good judgments. But if you ask him, do you want to have CPR and go on a ventilator, he's got plenty of ability to say what he wants to have done to him from a invasive or other procedures.
And hopefully you've asked that way before.
Yeah, and hopefully, I'm sure the oncologist has done that for a long time, but what it tells me is the guy's already told the oncologist that he wants to be treated, because he's now going to go get a kyphoplasty, he's going to do a PET scan and go back on treatment. So this is really what we call survivorship, and it's more about the patient than the disease. So put that first one up there. Ray was talking about, here you go, BKP, what's that say?
Life expectancy with COPD.
That's what Ray was talking about, all right? So that he's got his patients. Now pull that next one up there. Now this is exactly what Ray was talking about. So this beautiful thing, he's got mild COPD. That's the one he was talking about, who said doesn't have any symptoms. But he might get winded with moderate exercise. That's where I asked the question about running across the parking lot. And Ray says that he's testing him and his airflow is 80% of normal. So you got mild, moderate, moderately severe. Well, this guy, by definition, has got very severe lung disease because he's got low oxygen levels, they told you, because he has to have constant oxygen.
And he fainted.
Yeah, shortness of breath, okay, and he fainted. So his airflow is now down to less than 30% of normal. That's called the FEV1.
By the way, Bill, the mild square that you're looking at there is where you want to find them, and that's, as you pointed out, the hard place to find them, because they're functionally not
no
really,
symptoms.
They're asymptomatic, and they're really, unless you
pull
say,
that one down now.
Can you do your usual heavy thing? Can you get up that hill? Can you work that garden?
They pretty much can, unless you really put them to it.
And so what I found works best is to, if they are at risk, if they're a smoker, is get the pulmonary function test and show them the number.
Yeah.
Because they can't tell.
Right, and this could be asthma, it could be allergic bronchitis. It doesn't have to be tobacco.
Are these also, let me just put this, because I'm looking at the 1, 2, 3, 4 in the stages. Is this also age related?
No.
Not age related?
it's what we call a pack burden. How many pack years do they have? On their body?
Define pack years.
One pack of cigarettes per day for a year is 1 pack year.
And two packs a day is 2 pack years. And
so you can have
a
somebody
pack.
smoke like 10 years, 2 packs per day. That's 20 pack year burden. I have patients that are 60 pack year.
Yeah, but when you get to 40 pack years, you can go get those CT scans for.
So this is not age related, like, you know, in your 20s.
Well, wait a minute.
Because see, like if you know people that have never smoked.
Yeah, well, let's go back.
It's somewhat much like yourself that is a jogger, and up till recently would do marathons and all kinds of stuff.
And still exercise 80 minutes
still
a day.
exercise
Okay,
every
let's go
morning.
back. Because Ray didn't mean to say, this is not age related, but it is time related.
Time related. That's what I'm trying to say.
It
So
takes a
pack
while.
years.
It takes a
Right.
while to smoke 40 pack years.
Yeah.
And if you've got allergic bronchitis and asthma that you're not caring for, then you don't get damage on the first day. You get damage on the 20th
But
year.
let me change the question then. So COPD, is that something that you could have and have to deal with as a non-smoker?
Oh
Yeah.
yeah.
So that's why I was saying, if you're a non-smoker at all.
Allergic bronchitis and asthma is a big number.
Okay.
And the industrial exposures, but much less now. We have much better care about what people work in. But veterans that worked on Navy ships around asbestos.
How about people from Copper Hill working in the mine over there?
I used to literally have people come in, a swarm into my office when I first moved here, and I knew something had been released in a mine because I'd have 4 or 5 cases in my office in one afternoon. But it's subtle. It's hard to figure out, and these people need to be identified early and motivated to stop the injury. They need to stop the injury, because if you look at the progression of COPD, whatever lung disease function you've lost, it has a curve where it's going to go on down that's much more abrupt than a normal person, okay? But if you stop the injury, then they don't get better, but that curve flattens out and they live longer.
Right.
And you can slow the progression of the disease.
Let's go back to the young person with asthma, allergic bronchitis, chronic sinus all the time, who just says, well, I'm sick much of the year with sinus and I wheeze. So if you're wheezing, then you've got an airway obstruction.
Right.
Okay, now, over time, when that starts destroying the walls of the air sacs, that can never be redone because the air sac's destroyed. But you can get, right now, when they're 18 years old or 25 years old, appropriately treated for allergy and with bronchodilators and so forth, you can get that tube to open up and the wheeze is gone. So you've stopped the thing that makes the destruction. So now you're smoking, that's causing the same physiology. It's causing that airway to go bad and to get all full of mucus and stuff, and so it's not allergic, it's tobacco related. So if you stop smoking before you've eaten those holes up there, but beaten the lung up there, it's going to stop. Well, actually, it doesn't totally stop it, but it slows its progression. So you want to hit this when somebody's 20. If it's asthma or something, you want to try and get it in their 20s. If they're smoking, you want to try to get it to them as quickly as you can, whether they're 16 or 36.
What are the identifiers of this? When does somebody at home say, I better go see a doctor?
If you're injuring yourself, go see your doctor and get a baseline.
Well, here you go. If you're producing sputum, when you wake up in the morning, cough up sputum. If you have exercise, that's why I said if you can run across the parking lot, you'd say, look, if you got a garbage can and you have to go up the stairs to get out of your apartment and take it across the street, you get short of breath.
But
so you try to get it to something that's daily in their life. Can you walk up 2 flights of stairs if the escalator is broken in the store?
Those are good
sort of
functional
thing.
questions, Bill, but my point is even stronger. But these patients know they're hurting themselves. And if you made that choice, so be it. But if you are, go find out how hurt you are.
But the ones that have asthma
But there's
and stuff,
no-
they
Asthma,
not know.
they don't know.
They don't know.
Once you asthma, that's why I'm getting bronchitis. But once you have COPD, you can't reverse that.
Can't reverse it. We can slow
Can't
down the
reverse it.
progression.
But you can slow down the.
It's
you slow
usually the
down,
number one or
You
two.
can't stop it. Just slow down the progression.
It's usually the number 1 or number 2 cause of admissions to hospitals.
All right.
It's that severe.
All right. I didn't mean to interrupt
That's
you.
okay.
It was
All
just-
right, so we can put up the next one. Because this is
Unintentional weight loss in older adults.
okay, unintentional.
Yes.
Now, this is a whole category in itself.
By the way, I did the math on this patient you just presented. He was losing a pound every 2 days.
Yeah.
That's severe.
That's severe. So,
I mean, I open up and say things on the show. I had this happen.
you had unintentional weight loss?
Was that funny? What the hell was so funny about that? Was that funny?
No.
Did you
Pull
hear a
that one
joke?
down.
Did you hear a joke? I came to see you when I had that unintentional weight loss.
You did.
Yeah, and that
God.
actually, but you weren't really older.
We're not older adults, but
Yeah,
I mean,
so
the word
He had
unintentional.
the cause. He had the cause.
Yeah,
in
Yeah,
that
a
list.
lot of times you'll see this in diabetics because they're spilling urine,
Bingo!
they're spilling urinary sugar and stuff. Okay, pull that one down. So first of all, we just look at an algorithm that not a guy that's got cancer. Okay, so just imagine that you've got somebody who's got some age on them, and they've lost. Now this is less than 5% in 12 months is the definition. We're talking about 20% in 6 to 12 weeks, okay? Mm-hmm. But if you're lost 5% of your body weight in a year and you don't know anything's going on, then there's an algorithm that you go through here, and a bunch of it over here is psychosocial stuff. You got new medications, or, is your wife deceased and not cooking for you? Then on the opposite side, you've got physical things, you've got laboratory things. You can pull that down now. But one of the most common causes I see of markedly involuntary weight loss in the elderly is what is called pulmonary cachexia. It's chronic lung disease, and they are using so much energy to breathe, it's like they're running a marathon. They don't realize it. So they're using up calories to breathe sufficiently to lose a ton of weight. All right, get the next one. We're going to talk about this for just a minute. But in the unintentional weight loss, patient has no prior diagnosis. Cancer is only about 20% of the reasons. All the rest of the reasons are on here. Psychiatric is 5%, so pull that down now. But you don't make a diagnosis, and there is no diagnosis is the biggest number. That's 1/3. So this particular guy that we're talking about here, I think his weight loss is psychosocial because he was alone and he had a broken back and he's not getting enough food to eat.
He's in pain. Not eating.
In pain. They didn't tell us that he lost his weight while he was in rehab and somebody was feeding him. And by what the oncologist did, you're pretty sure that he's convinced that it's not progression of the disease, it's nobody's there to feed him. So what did he do? He got a social worker to call his church or something and find some friend that would take him into the home and feed him. So the next thing is, let's get him out of pain with the kyphoplasty. Let's fatten him up with the friend. Let's reassess his malignancy with the PET scan. And the immunotherapy that he was teaching was just like what we talked about in the first question of Jimmy Carter. That's not causing him any symptoms. So no, don't go to hospice. Sort of support your dad where he is and hope that these things all work. That's the answer to that question.
The new primary care nuance on that is that we worry more about the patients that have a slow but subtle weight loss that finally come in and say, I've lost 10, 15 pounds, I've notched my belt once and I wasn't trying. When I hear that, then I'm going to run through that mental list pretty quick, which is fairly simple. And then I'm going to.
Well, it's got lots of different things.
Well, it's lots of different things, but I mean,
the
you can
psychosocial
mentally
side is
work
history, and most of it's going to be history.
Most of it's going to be history, but then it's going to come down to, well, you know what? I got to rule out cancer here,
or diabetes, or
those I can do simply, but I got to rule out cancer. Are going to go to Bill Whaley, but my pet peeve I'm trying to get to here is that, geez, I'd like to work them up a little bit before I send them to the oncologist to get some questions answered. Right. And now I got an argument with the insurance company saying, well, weight loss, you don't need to be getting an x-ray for weight loss. And I'm like, yeah, I do. And I can either order it or you can let Dr. Whaley order it. But now I've eliminated everything else, and I've got to make sure they don't have occult cancer somewhere, and they're going to get some studies done.
And that's 25% right there.
Well, let me say this. I know we're talking about cancer, but we've ventured into.
He's talking about fighting insurance companies too.
COPD, but we've gone into unintentional weight loss.
Right.
And this is not where you're getting up and you're doing the calories in, calories out, as we've discussed. You're nothing changed. Nothing changed in your diet. You didn't change anything. And you have, in older adults, you have unintentional weight loss. That's something you need to go check with your doctor.
Well, you need to go check with your doctor, and hopefully a family member's pointing out, saying, "Dad, your pants are getting awfully baggy here." But really, I'm making a pet peeve. A good primary care physician can work through that differential in their head in one visit. And so by the time
But not if the patient doesn't come in, they can't.
If the patient come in, they can't do it. But once they've done it, and then they say, "Well, I've mentally ruled out the things that are easy. I'm not going to use the C word on you, but I want to get some x-rays or some studies done. You've been smoking for 20, 30 years. I need to do this and that." Whatever. It's ridiculous that we have to get a pre-certification to get an x-ray done for a clearly obvious indication.
I was losing weight and was not trying, and I could not quench my thirst.
Yeah.
Could not at all, so...
Yeah. So
I had to go.
You had the classic polydipsia, polyuria, drinking a lot, peeing a lot, and losing weight. It's a diabetic to prove otherwise.
Okay.
Okay. Well, we got the news of the day here. We're gonna.
But the key thing is, I went to the doctor, and I have it under control.
Well, you went to the doctor because the doctor was here every week telling you to go to the doctor.
Oh my gosh! I'm trying to encourage men to go to the doctor.
We had to beat him over the head. All right. There are 25 things in the news today, and one of them, I showed you this, that the positive tests for COVID are up to 10% from 3% last week, and that's because we've got a new variant called the BA2 of the Omicron, and I'll just quickly go through this. 2 weeks ago, that was 7%. 3 weeks ago, that was 7% of the tests. 2 weeks ago, it was 13% of the tests. Last week, it's 23% of the tests, so we're talking about involuntary weight loss and stuff. That's really rapid. And that is what's coming in now. It doesn't make people very sick. It is much more infectious than Omicron was. So in the natural course of events, I think everybody's going to have this thing pretty quickly, and they're going to have some antibodies. And the next question is, how long do the antibodies work? So anyway, that's what's going on with COVID. It's going up again with a new variant.
Can I emphasize that?
Yeah.
COVID is around. It is going to be around. It's going to be floating around the earth for who knows how many more months or years. It is treatable when treated early. So don't be afraid.
And most of these people aren't going to need treatment anyway. They're not going to be sick.
9 out of 10 of them are not going to need treatment.
Right.
Probably 99 out of 100 are not. But it is treatable. Yeah. That's the whole point, is that you need to get into treatment early if you get sick with it, and you need to not be afraid of it, and you need to go on with your life, and the fear porn people are still there selling their fear porn.
All right, I want you to read this, because this is a big number right here.
With fewer PSA tests, rate of advanced prostate cancer rose.
All right. Now, what's Ray and I have been
What's that due to?
What Ray and I have been talking about forever. Early detection, do your mammograms, do your PSAs. You'll remember it has been, and I think the people in the green room over there asked me this question. The recommendation made about 10 years ago by some regulatory body was you don't need to do PSA tests on people over the age of 65, or was it 70, something like that, because they aren't going to die of prostate cancer anyway. And then after a few years of that, they said you don't need to do routine PSAs at all on men. Discuss it with your doctor. Well, that got people to where they didn't think about it. The doctors, it came out of the routine panel that an insurance company would pay for when you went in for a health screening. For example, you work at Delta or Walmart or somewhere, and they send you for a health screening if you're at a certain level. Then the test they do is they have a blood sugar and an A1C and a cholesterol and a PSA if you were a male over age 45 or 50. They pulled that out of these routine panels. So that 900,000 people were put together in this study. and the number of people who had advanced high-grade prostate cancer that'll kill you went up by, what was it, Ray, 28% or something in that period after this was done. So this is a regulatory recommendation that when put into practice is killing people.
Then, I mean, it's interesting because this really parallels almost exactly my career. As I came out of my medical school and residency and training, I routinely saw advanced prostate cancer patients. A terrible disease. Painful, bone mets, hurt, not good options, not good surgery. I mean, just a terrible disease. Commonly saw that as a resident. 10 years ago, never saw a case. You didn't see a case. Patients were diagnosed with prostate cancer early, treated early, observed, whatever we needed to do. It was, the cancer was beat down.
Way down.
And way down. I mean, it's just like wasn't even on my radar anymore because we did PSAs. And I told my patients, I don't care what the number is. I want to know what the annual number is.
Yeah, well, how's it changing? I want to know,
is it changing? Okay? If it's changing a little bit, we'll talk about it. Changing a lot, you're going to go see somebody. Okay? That's the way we do this. And when we do it that way, prostate cancer was whipped. And then we get the, let's save a little money here. Stick our head in the sand.
Well, that way it wasn't. It wasn't just money. It was the fact that after you had the elevated PSA, people were kind of going overboard with what they were doing to work it up. They weren't thinking through it.
It's still money.
Yeah, it's still money. Okay, right. It's still money. They're worried about money. And it's like that body scan. Come down here and get this body scan for $150. The reason that people recommend not doing that is because if you have a small pulmonary nodule that's tiny, the radiologist, in an effort to protect himself from malpractice, will say there is a confluence of shadows in the right lung of 1/2 centimeter in diameter, could be inflammatory, but malignancy cannot be ruled out. Clinical judgment is suggested. Well, no doctor can ever look at that and not do something, because if it's lung cancer, the lawyer with the alligator briefcase and the shoes is going to come get you in 4 or 5 years for malpractice. So that was the logic of the regulators, but they made a mistake.
Well, it's one of the hypocrisies of our industry. Over-testing, over-surveillance is a problem, and it's an expense, and you can figure out how to cut that expense down. So why in the world are we running around testing everybody that wants to for a COVID bacteria?
All right.
Do we not learn anything here?
Yeah, but you're late for work.
I am.
Yeah, you're
but
late
he's
for
not.
work.
He can stay.
You're late for work. You got a final? Did you have something this morning that you wanted to say?
Donate blood.
I always like to give you guys. You got something?
I'm running out of jokes here, but I got a grandchild joke. Did I tell you about what a Tyrannosaurus Rex is? If they sold guns.
Wait a minute.
A Tyrannosaurus Rex.
A Tyrannosaurus Rex.
You picturing a Tyrannosaurus Rex here?
Yeah. If they sold guns.
Yeah. Small arm salesman. Tell that to the
kids. We're leaving on that. We're leaving on that. Thank you. Right after.
Green room.
Thank you, Georgia Cancer Specialist, Northside Hospital, Cancer Institute. Amazing questions that these guys break down every Friday morning. We'll be back with the All-Star Political Panel right after this.